this is the steps that we don't want you to reach. It's the complication. But whatever you are a skillful surgeon, you will encounter some of these complications in your career. And it's very important to manage the complications. Okay, if the complication happen, if you manage it properly, you can have even a good outcome. But if you get panic and you did not manage it properly, you will worsen the situation. The timing of complications, it can happen preoperatively, it can happen during surgery, and it can happen immediately after surgery. And sometimes you can have late complication. So sometimes you do things you think it's proper, but at the end, the patient will come to you after 1 month, 2 months. Patient, he said, my vision is worse than what was it before the surgery. Probably it was mentioned, this is very, very important. Maybe we just fully depend on our technician to do the IOL calculation, but this is, I think, very important to review the IOL calculation. Nowadays, we are facing a lot of patients who had Lasik, and during doing IOL calculation after Lasik, this is probably a whole lecture, and this is very important to use the right formula to do the calculation for post-Lasik patients. And also, maybe it was mentioned, some of this by Dr. Justanis, the corneal opacity, high myope, dense cataract, you need to have special consideration to avoid any complications. Also, some of the anesthesia complication, it was mentioned, I will not go over it again, and also some of the commonly used anesthesia nowadays, for cataract surgery is local anesthesia and topical anesthesia. And rarely we are doing general anesthesia, except in few cases. And like mentally retarded patient, like claustrophobic patient, we can consider doing GA, or if we need to do like bilateral cataract surgery. Usually it's not the rule. I mean, retropulbar hemorrhage, this can be also seen after, for example, retropulbar anesthesia. So most of us, if they are doing local anesthesia, we can choose peripulbar anesthesia, so to avoid more complication. Some of those patients, they might be on anticoagulant medications like Plavix, like warfarin. So you have to be sure, when you preoperatively, to make sure that this patient is stopping this medication. Globe perforation this is one of the a very bad complication if it happened. And also it was mentioned earlier that if you have high myopic patient, you have to be careful, because those patients, they might have staphyloma, and while doing the anesthesia, they can have perforation. And this is some of the images after perforation. Nerve sheath perforation also it can happen. They can have what we call a central spread of the anesthesia. We did pain and anxiety. This is a study to compare topical and peripulbar anesthesia and cataract surgery, and we found that topical anesthesia, the pain and anxiety is even comparable or even better compared to peripulbar anesthesia. Intraoperative complications, we have every step of the surgery they can have complication. We can have wound complication, we can have corneal complication, iris complication, anterior capsule, posterior capsule, vitreous, choroidal hemorrhage. All of this can happen. So you have to recognize it when it happened. The wound, I will not go over it because it was discussed by Dr. Justani, and I will probably I mentioned early that incision is very important at the end of the surgery. If you design your wound nicely, you will avoid having leak, and with this leak, this patient can have an endophthalmitis. And sometimes we see the patient first postoperative, and if you noticed, sometimes we don't check the wound, but it's very important. If you're suspecting, for example, the pressure of the wound is low, or you see some corneal folds, make sure, suspect there is a tiny wound leak. Also, I will not talk about this because of the time, and also it was mentioned here. Okay, this is the burn. This is a image of the burn, and there are certain things we just mentioned earlier. Is too much outflow. Tight wound can induce the thermal wound. With the femtocataract surgery nowadays, we can design the wound the way that we want. So we can have the 2 steps, we can have 3 steps, and we can have it as long as we need it. Iris complications, how it happened, the complication to the iris. You know, if you have positive pressure on the globe, if you have very tight lid speculum, and this is very important. I noticed it with some of the residents, they want to have a good exposure, but the problem, so choosing the speculum is very important. So if you have a small eye, you don't need to use big speculum, so you have to be careful. And sometimes we try to open, and this will squeeze the fornices, and you will have a lot of vitreous pressure while doing the surgery, and you wonder what's happening, you know, while doing it. And also, if this patient received some anesthesia, make sure, you know, if the orbit or if the globe is small or the eye is small, ask how much of anesthesia this patient is receiving, or sometimes you don't need to give a lot of anesthesia. Floppy iris syndrome, this is another problem, and it will give you a difficulty while doing, you know, surgery for those patients. And those patients, probably they are on medication for prostative. He's a male patient. Unadjusted fluidics, and the machine can also do some iris complications, and large incision can induce a lot of wound leak. Optimum visualization is very important, and this is very important to understand the operating microscope before starting your case. So if you are not sitting properly, you will add to yourself another stress because you are not sitting properly. The other thing, if you are not seeing properly, maybe you are not doing the microscope properly, or you are not using the proper, you know, focusing, proper zooming, and in phacoemulsification, we should not stay in one zoom or one focus. You have to change it according to your step. So you need to play with the microscope properly. You need to understand the microscope well, so you can do successful surgery. Because if you don't see well, sometimes, you know, if you have corneal opacity, you may need to just use the autoflux or the red reflex. This will help you a lot, so it will give you better visualization. This can happen if you traumatize the pupil margin with the phaco-tip. You can have distorted pupil, and in this case, multifocal lens cannot be used. Sometimes, you know, we feel, you know, the pupil is small, and sometimes we have a long list. We don't want to use, you know, iris hooks or Malugin rings, so it's better to use it. It will make it very easy and successful surgery. And also for floppy iris syndrome, it's very important to use Malugin. This will stop the iris from moving while doing your surgery. Decimate detachment, as you can see in the OCT there, it's also another complication. Sometimes you cannot recognize it if you have a corneal opacity, but in the first postoperative day and week, this patient, you know, corneal edema may not resolve, and sometimes you cannot see it, and you need to do an OCT. This is some of the images of the phacoemulsification. The anterior capsule complication, you know, like the radial tear, this is one of the complications that you can encounter, and this can be seen in mature intumescent cataract, and can be seen in young patients. So you have to use the right parameters, and you have to be careful while doing this, because if you have it, this might, you know, be the beginning of other complications. This is also mentioned. I will not go over it. Nuclear removal also. Okay. Okay, the rupture posterior capsule, this is an ECCE. It's very easy to control when you have posterior capsular tear, because usually, you know, you will not have a lot of fluidics going into the anterior chamber. But for the phaco, whenever you have capsular tear, it's because of the high flow and a lot of irrigation inside the eye. This will push the nucleus inside the vitreous cavity, and this is a disastrous complication. You need to probably refer this patient for a retina surgeon to clean the vitreous and the eye from the nuclear parts. Also because of the time. Okay, vitreous loss in phaco usually happen during phacoemulsification. As I said, you know, it's worse in phaco compared to the ECCE. When you have an unstable or tilt nucleus, you should stop. So sometimes when you start and you notice there is instability of the nucleus, maybe at this stage you have to stop. You have to make sure there is something wrong. Maybe there is a weak zonules, or there is something you need to take care about it. And this is when you have, for example, zonular dialysis. So maybe at this stage you have to stop, and you may use capsular tension ring to strengthen your bag, and you can complete your case smoothly. One of the complications that you don't like it to happen is the drop nucleus, and if there is a posterior capsular tear or parts of the nucleus remain in the view, the surgeon enlarge the wound and deliver the nucleus with the lens loop. So it depends on what stage, because there is a lot of controversy, and it depends also on the experience of the surgeon, when to stop and when to complete the nucleus with the phaco. Sometimes if you are just starting and you have a very big posterior capsular tear, probably it's safer to stop at this stage and try to use, for example, lens loop to deliver the nucleus through the wound, and of course by enlarging the wound. Expulsive hemorrhage, this is a very rare complication, and it's better to be controlled with the phacoemulsification compared to ECC, because in ECC you have a large wound, and when you have it, maybe it's very difficult to stop the bleeding. But in phacoemulsification you have a small wound, and maybe you can manage quickly to close the wound and make sure that the expulsive hemorrhage can stop. There are certain cases you have to predict, when you start your cases. For example, if you have older patient with pronascent lens, this is a risk. Pre-existing uveitis, high myope, glaucoma patient, systemic hypertension, all of this can be risk for an expulsive hemorrhage. Also, postoperative complication, there are certain complications like wound leak, hypotony, hyphema, iris prolapse, high IOP, corneal edema. And high IOP, this is sometimes we encounter it because we leave some of the halon or of viscoelastic in the eye. So make sure what type of viscoelastic you are using for this case, because some of this viscoelastic you have to clean it, and sometimes you have to go even under the eye to clean this, because some of this is very viscous, and it will be difficult for the eye to clean it. Eye will capture, it's rare, but it can happen. Decentered eye will and dislocated eye will. Pupillary block glaucoma also is rare. Endophthalmitis, this is one of the major complications after cataract surgery, and this is another subject. The late complication that we have to be careful about it is, for example, cystoid macular edema. This is if you have a patient with that the vision did not improve fully, you cannot see anything. Maybe it's wise to do an OCT for the macula to rule out any cystoid macular edema. Posterior capsular opacification, there are many reasons for the PCO, and one of the reasons is if you don't clean the capsule nicely. Some of those patients you need to clean the capsule nicely. For example, high myope patient, because those patients you don't want to do YAG capsulotomy later on. So make sure that you clean it. But at the same time, sometimes we try to do excessive cleaning, and unfortunately we might injure the capsule while doing this. Capsular phimosis, this is when you do the small capsule rhexis in uveitic patient and younger patient. You can have capsular phimosis, and maybe you can do radial YAG capsulotomy if you open it. Phototoxicity, for example, if you prolong the surgery and if you have the maximum light intensity, this can damage your retina. Retinal detachment, and this also can happen if the patient had complication, vitreous loss. You are trying to build the vitreous while doing the surgery, they can have retinal detachment. Maybe this is mentioned. Okay, well, not mentioned. Glaucoma also, this is another complication that can encounter us after cataract surgery, like primary open angle glaucoma. If this patient IOP is borderline, the surgery can induce or can increase the IOP. If there is a blood, or if you lift some cortical material, and the most important thing is with the viscoelastic. So you have to make sure that you clean the eye well and nicely. Closed angle glaucoma, if you have pre-existing angle closure glaucoma, pupillary block, malignant glaucoma, neovascular glaucoma also we can encounter it. Endophthalmitis, as I said, this is a major complication, and always you have to see your patient. As mentioned by my colleagues, you have to advise the patient if he's complaining of pain, decrease of vision, he should come immediately, because as you know that endophthalmitis, if you treat it on time, you will save this eye. And corneal edema, this is, there are many causes. You have trauma during phacoemulsification, you might have decimate detachment, or we might have what we call a TAS syndrome, or sometimes high IOP, but in this case you will have more of a stromal edema or epithelial edema. Cystoid macular edema, you know it. There are some problem, you know, you can encounter also later after cataract surgery, what we call it refractive surprises. Patient might be myopic because of the wrong IOL. This is very important to be sure this is the IOL calculation is for this patient, and I'm always doing both eyes to compare. If you have huge discrepancy between the power of the two eyes, there must be something wrong, so you have to repeat it. Okay, the hyperopic patient also, stigmatism, you know, you have to maybe tackle it. One of the major complications that we encounter in some of our patients is glare after cataract surgery, and this is also, there are reasons for it, but maybe not the time to explain it. PCO is another complication which was mentioned, and thank you, because of the lack of time, we cannot go to every part of these complications. Thank you all.